Hey Mo,
Hey, Ricky, how you doing?
good. The doctor is in.
Yes, yes, we are. We are in with a special episode of The
Oh,
Doctor is In, and it's about to get even more special. Wait for it.
you wait for it.
Oh,
Here it goes.
Perfect timing. We just went live. Dr.
Oh my
Regina.
goodness.
I'm surrounded by my favorite docs. I'm so happy.
hmm
And
I
my
got
favorite thing.
to share this. Everybody's top 4 moments. Share this on your Facebook because we want all the links to know and to be aware that we are holding a special episode because I think we need to highlight the work of this organization and the members and really the impact that it can have on the community. And there's a good model for that and for community partnerships with national organizations that are impactful in the Black community. So we're talking about it. It's Links in Pink. Here it is. First annual.
I know, Links in Pink, our first annual Links in Pink.
Wow. Welcome, everybody.
How are you guys?
Yeah, hello.
hi.
So let's let everybody introduce themselves. Tell us who you are, where you're from, what you're doing, why you're doing it, and then we're going to dive into some of the issues coming out of Breast Cancer Awareness Month and what people should know. So who wants to start? Dr. Dunmore Griffith, would you like to start?
Sure. Good evening, everyone. My name is Jackie Dunmore Griffith. I live in Prince George's County, Maryland, Mitchellville, and I am a radiation oncologist. I am part-time faculty at Howard University College of Medicine, and I oversee breast cancer treatment in the Department of Radiation Oncology there. And I'm also on staff with the Luminous Healthcare System in Lanham, Maryland, and I'm a member of the Radiation Oncology Department there as well.
Cool. Great to have you. And Jackie and I have known each other
Since I was 3, maybe.
yeah.
Yeah.
Yeah. So we've known each other for a very long time.
I love this. Are you in the same chapter or are you in different chapters?
No, I'm in the Metropolitan DC chapter of the Links.
Okay.
I'm
Gotcha.
Silver Spring, Maryland chapter.
Okay.
All different, right? Right.
Gotcha. Dr. Horton, how you doing?
Hey. So I'm so glad to be here with Links and Pinks. I'm Sarah Horton. I am a medical oncologist based in Silver Spring, Maryland. That's where I live now. I worked many years with Dr. Jackie at Howard and still have an affiliate association as an associate professor there with their breast clinic. I work with health disparities and Black women in breast cancer. Right now, my job is actually with a nonprofit spinoff in San Francisco called Quantum Leap Healthcare Collaborative. It's a spinoff of UCSF, and I work with increasing diversity on clinical trials that are under their umbrella, and I'm their Director of Access and Diversity. And I'm a proud Link member of Metropolitan DC with Jackie. And I've known Ricky for many years too. Mo a little less, but for a few, right?
Yeah. Her mom was really my best friend before.
Yeah,
Oh,
she
her
was.
Had
My mom passed this year from lung cancer, but she had breast cancer many years ago, very early, and that's kind of a part of my why too.
yeah, she was awesome.
That's
Yeah.
beautiful. And
And
Dr. Regina is no stranger to touch on our medical advisory board and just all around badass with cherry blossoms and everything else. So tell us how
my
about you.
doc, and she's my doc.
Hi, good evening, everybody. I'm Regina Hampton. I am a breast surgeon. I'm the chief of breast surgery at Luminous Health Doctors Community Medical Center. I'm also the co-founder and interim CEO for Breast Care for Washington, which is a nonprofit in the Washington, D.C. area that takes care of women and provides mammograms for women, whether they have insurance or not. And I'm also the co-founder of Cherry Blossom Intimates. We are a bra and intimates boutique located just outside of Washington, D.C. And we're a bra and intimates shop for all women, all sizes, and also a certified mastectomy boutique that takes care of breast cancer survivors and provides them with their undergarments after their diagnosis and through survivorship.
I love that. And you all know me, I'm Dr. Bo. I am representing the Montgomery County chapter, Pennsylvania, chapter of the Lynx Inc. And I'm the breast surgeon and director of the cancer program at Grandview Health out here in Sellersville, Pennsylvania. And co-host of The Doctor Is In.
Yep. And I'm Ricky Fairley, and I'm Silver Spring, Maryland Lynx, proud Lynx. And I love having all these awesome docs on our show today, right? On our special episode. So great. So great. And we've had
Oh,
a,
I didn't mention my chapter. I'll get in trouble.
oh yeah,
I'm part of the Washington, D.C. chapter.
yeah.
Represent. Oh, I love it. Mid-Atlantic is representing. This is beautiful.
I know if any other Lynx doctors want to come on, text me and we'll bring you on. We try to get more doctors. We kind of pulled this together, but this is something, you know, we've had a very, very, very busy breast cancer action month. A couple more events to do today and tomorrow, but there's so many issues that have come up this month just about Black women and screening and clinical trials and, you know, all the same things. But I feel like there's been a higher level of intensity of conversation, and we've done a lot of talks, a lot of events, but I do feel like we're getting a lot of attention these days, more so than have gotten in the past. As you know, we know that breast cancer affects Black women the most at any stage, any age, any subtype. We have a higher mortality rate than white women, no matter what the circumstances. And we need better stuff. We need better treatments. We need new ways to think about it. And I know you guys are all in the trenches doing this work, but I do feel like we're getting attention now from our pharmaceutical partners and even from our community. And I think we're talking to more women who are acting on their care, you know, and I'm so happy about that.
Dr. Sarah, let me bring you in on that point because, you know, we've been saying these same disparities for years and years, and every season, every year we're able to talk about these and recite some of these numbers, but do you get a sense that the tide is changing both in clinical research and among the medical oncologists and their perceptions about what's important in clinical research? Is the message getting through to clinicians, you think?
I do. And I do because there has been this change in how we are shining the light on where the disparities are. In the beginning, it was focused on patients. You know, patients aren't doing this. Patients aren't participating and not really focusing on the why. And so we got to this point after we were identified that there was this disparity, that there were a group of patients who were not involved in research. And there was some research done on that. And it was found that, you know, despite what people think, especially providers and doctors and people who treat patients, people, especially of color, there was an assumption that we didn't want to be involved in clinical trials for all those reasons we always talk about, you know, because of it's an experiment in Tuskegee. But, you know, there's been enough research to show that, yes, a Black patient will be just as likely to participate in a clinical trial as a white person or any other person. So we're at that point. We know that asked, we'll participate. So that message is out. And now the message is being focused to the clinicians. Look, you might have a bias. You know, doctor, why aren't you asking patients? Let's talk about how you can engage. What is the problem? Is it a comfort level? Is it a words level? Is it a language thing? So there's a lot of focus on teaching doctors and practitioners and even researchers about the fact that you need to assume that minority patients want to be involved in clinical trials. And so I love that. And that's a lot different than, 20 years ago when we started with this, where the assumption was nobody of color wanted to be involved in studies.
And what about radiation trials? Dr. Dunmore-Griffith, would you come and weigh in and talk a little bit about what you're seeing as far as patient interest in participation in trials and the data that you see out of ASTRO and things like, how's it going in your specialty?
So in radiation oncology, unfortunately, there are not a lot of trials specifically for breast cancer, but there is some data that's been coming out to show that some patients could actually not get have to have radiation with breast cancer. So that's some new information. So clinical trials are really important because when patients do get into the clinical trials, not just from a medical oncology standpoint to see which chemotherapeutic drugs may work best or what type of surgery may work best, it's also giving us information about radiation and whether or not every patient needs radiation, whether we have to do a full course of radiation, treating the entire breast, whether we can treat a partial breast, and how this compares. And so there has been some promising data that has come out recently that has shown we can, for early stage breast cancer, some patients, depending on the type of breast cancer they have, and they're over 55 and they have low grade disease, they may not even need radiation therapy. There's some other data that has come out recently that has shown that we don't have to treat the whole breast for 6 to 8 weeks. We can get away with a 5-day course of treatment for some patients. So clinical trials and the information that come out does actually change the way we practice medicine.
You know, Dr. Jackie, we did this event a couple of months ago, and we learned about stage 0 from Karen Gadek at Emory. Dr. Karen, and she was saying how there's now a technique where when you have surgery for stage 0, they can actually radiate you on the operating table, like in the surgery, which is then you don't have to do it afterwards, which was pretty interesting. It's pretty cool.
Yeah, it's what we it's like an intraoperative radiation therapy where a beam is directed right at the tumor bed while the cavity is open. So
right.
yes.
That's pretty cool because stage 0 is still so wonky, you know.
Mm-hmm.
Yeah, they're studying that for invasive disease too, where I trained
Right.
at, shout out to Hospital Center in Georgetown, right? Because of the Target A trials, all those Target trials came out of came out of Hospital Center in Georgetown, and there were Black women in those trials, and I remember recruiting and explaining and signing them up for it. So it was very progressive, I think, even in the early 2000s to really get Black folks into these trials and start looking at not just the standard of care, but advancing the science a little bit, right? Can we be a little less toxic? Can we save people some copays, some trips to the hospital? Because it's a hardship, and if it has comparable survival and comparable local recurrence rates, it might be a good trade-off,
Indeed.
Dr. Hampton, you want to weigh in, Dr. Regina, on some of the diversity in surgical trials that we're starting to see?
Yeah, I think it's important for people to know that clinical trials don't always have to mean that you're getting an actual treatment or some form of medicine. There are clinical trials where they're asking questionnaires and just monitoring people. So, I think that's really important because as Sarah mentioned, people often think, oh, we're going to be like a guinea pig. But I know when we look at surgery and the important trials that came out of surgery, it's clinical trials is one of the reasons why we have lumpectomy as an option. It's clinical trials because we now see less lymphedema because we can do sentinel node. And there was just a recent trial that came out and said we might not even have to do sentinel node on a select group of patients. So, clinical trials is how we advance science. And people have to realize that it's because of the history of clinical trials on why clinical trials are now safer. You have to be given information. No one can just, take your cells without you knowing about it. It's a more open process. And it's the reason why so many women are survivors. It's because of good clinical trials.
Mm-hmm.
Yeah, that's great. We need more science.
We do, and I think we need more health literacy too, even before we get to the point of offering somebody a clinical trial. Would you say that we're still seeing more advanced disease in our community? Because I feel like those statistics are still, when we kind of go down that list, we're more likely to present with advanced disease. And is it due to lack of screening or delayed screening, do you think? Is that still kind of the sentiment, or is there more to the story than that? What do you think?
I think there are just still some communities that don't know the stats for Black women. And so when a younger Black woman comes in, they're just not aware that, breast cancer could be a reality for that, woman who's between, 25 to 45.
Right.
And so that's where I think it becomes really important that women advocate for themselves. I was on another call earlier this week where a woman said, the doctor said I was too young and I just believed them. And it wasn't until another 6 months later when she was actually diagnosed. So I think it's really, really important that, we really educate the public to advocate for themselves, to understand that as Black women, we can't ignore anything at no matter the age. I think like the youngest woman that I'm treating right now in my practice is 32. But I've seen some younger. And so, again, it's just really women advocating for themselves. And really, if any doctors are on, you've got to understand that when a young Black woman comes in to see you, you have to take that complaint very seriously.
Yeah, we're starting to see, we see so many young women, and 32 is actually even old sometimes. We just had one of our baby breasties, 23, get featured in an Essence article last week, and then we have our Ari that works with us, she got at 19. So it's, but that's a lot of the work that we do that Haley's doing, is just educating young women about their risks. And Amanda, she's 38. She just got a risk assessment from your office, Dr. Hampton, and it's 34%, so, but that's giving her the ability to have options. And so she's now, interviewing plastic surgeons to get the boob, her fantasy boobs. Because she doesn't have to worry about cancer, but now it's about, how big are they going to be and, what are they going to look like? So.
Yeah, so I agree. I mean, it's a combination of us presenting later at later stages. And part of that is because we don't get screened as much as we should, when we should. And that could be because of a lack of education, not knowing, or fear. Oftentimes we're afraid, so we present with later stages as well. And as Dr. Hampton was saying, it's not just a matter of educating the community, but it's also educating the physicians, because you're right. When a 20-year-old comes into your office, the last thing you're thinking about is breast cancer, right? So it is really important for us as physicians not to put it on the back burner and say, no, this person is too young, because you're not too young, right? So we need to do our due diligence, and patients definitely have to advocate for themselves. If you go someplace and someone ignores, the signs and symptoms, get a second opinion.
Go to another place, right? And
the young vaccine is 17 right now, 17, right? She put off her MRI to take her senior pictures. Like, come on, and she had been told by some doctor for years that this was probably nothing, but it was getting bigger and getting bigger. And, and to the fear point, there is still such a fear about mammograms. I was at a yoga event earlier today, and a woman who, organized all that every year. She's active in her community. She's getting the seniors, the silver sneakers, lots of things, but maybe has some fear about mammography still. And I think it's very real and it's valid, and we need to not only, educate, but meet people where they are a little bit too, because I think there's some shame associated and some fear there too.
Right. But that's why things like Bexa are so good too, because it gives them an alternative to a mammogram,
We need to advance the science in that too, Ricky. You're absolutely right. And Dr. Horton, what about genetics and genetic testing, right? Can we pivot and talk? Because I want to touch on a bunch of different things that we've all been hearing and talking about this month on all of our panels. And, so we got that family history, right? And maybe we know it, maybe we don't, because, we're not talking about it as much, but are we seeing the same advances in terms of having those family discussions and equity in genetic and genomic testing?
I'd like to think so. I will say that more women know what genetic testing is now than I remember. It's not a totally foreign term when people hear it. So that's a win right there. It was just making sure that this is not something that is left out of the conversation. So just along with everything else. And I think because genetics is becoming important in a lot of other diseases, we're all learning that this needs to be a part of a medical discussion pretty much, in anything. And so I always advocate, just like I advocate, just ask about a clinical trial, even if, just ask about genetics, because we're learning so much at such a lightning speed about markers, about genetic mutations and how they're involved.
Right.
We BRCA 1 and 2, that's all you heard, but we know now that there are other markers check, and we know that they're out there that have a significance on your risk for breast cancer, and they should be tested for, and it may impact what you should be doing. So one of the things that I like to always mention is if you've had genetic testing for breast cancer because of something in your family history, even, and it was 10 years ago, you need to go back to your doctor and say, you know what, I need to get full genetic testing, because we are looking at so many more genes and even parts of the genes that we looked at. So one, be up to date on your genetic testing if you were ever told you were at risk in the past. And then the other part of genetic testing is, let's see. So right now, there's not a standard for using genetic testing for screening, like for mammography, other than if you're BRCA, there are some recommendations made. So I'll very quickly just put a plug in for the clinical trial Wisdom, which I usually do, which I
Right,
work
go
with.
for it. We love Wisdom. We love it.
Okay, so Wisdom, and it's an acronym for Women Informed on, blah, 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 but it's all about making an informed decision on screening recommendations for breast cancer, i.e. mammograms, like when you should start and how often you should be screened. And this comes from the thought that not all women are alike, not all women's risk for breast cancer is alike. So why should one recommendation, one guideline that everyone start at 50 or 40 or 45 be for all women? And
Right.
so to be able to know when you should screen, we need to know about ourselves. And we know that right now we look at a woman's history in terms of, are they at a higher risk for breast cancer? Things like family history, and we take into consideration, how your age of having children, and did you breastfeed, and all of those things. But with the Wisdom study, we're also adding in genetic testing. And I want to preface this by saying this is a clinical trial that you do from your home. So this is not a trial that you have to get up, go someplace, take time out and do it. This is done online. And so this is for all women who have breasts. I will say the caveat is that if you have had breast cancer, then you wouldn't be a candidate for Wisdom, because you have some factors involved already. You should be followed by your oncologist for this. But if you haven't, you go online to thewisdomstudy.org, and it takes you through, and I'll just kind of give a very high level quick overview if I can, but there is genetic testing, which is a buccal swab. If you opt to do this study, it will be sent to you and you send it in. But what the study does is it looks at your DNA, and there are already, as we talked about, known genetic markers that increase your risk. And then there's some that are suspected that are involved in this study as well that will be tested for. All of that information is sent to you. And if you happen to have any of the genes that may indicate you have a higher risk, you get a call with a genetic counselor who explains all of this to you. So this is for you. Now, none of this information is given to anybody else. They say, do you want this sent to your doctor? So it can be sent to your physician, or you can do it yourself. So there's the personal.
Free. It's free.
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 All free. It's, this is,
Right.
it's based out of the Athena Breast Network in San Francisco, but it is available to all women. So you can get your genetic screening, you fill out a survey that asks all those questions that we all know are asked when you look for risk factors. And it talks about, your lifestyle changes, how you eat, how you exercise, along with your family history and kind of your estrogen exposure, your menses, and how many kids you had when you had kids. And then lastly, it looks at breast density, which I love, because we are trying to find out how breast density impacts your risk for breast cancer. And the only way to find out is to do the research. And so now that it is a national requirement that mammogram readings have an indication of what your breast density is, that information is being incorporated into the Wisdom study, taking all these three components, and each person then it comes up with a score. So you've got kind of a risk score from this algorithm that looks at your DNA information and your risk and your density risk. And then you will either be in high risk, standard risk, or low risk. And based on your risk, there will be recommendations that you either, if you're high risk, you alternate MRI alternating with mammogram every 6 months. If you're standard risk, which our standard risk is yearly mammograms starting at the age of 40. And then if you're lower risk, there are recommendations that you may be someone who can screen every 2 years. And if you haven't gotten to the age of, say, 40 yet, they said you may be able to start at 50, and it all depends on your risk. So when I first looked at Wisdom, and I love the fact that it's trying to answer questions that we need answered, because we're all kind of assuming things, was I said, in the population that I treat, African-American women, we know we've got higher risks across the board for breast cancer. I don't know if someone was put in the low risk category, would I be comfortable saying, don't screen every year? So it becomes a choice. You stay in the study. Once you get your risk score, you make a choice of what you would want. And so it's one of these things where even if you're a low risk, you say, you know what, I want to stay with my yearly screening. You stay with that, but you stay on the study. We still look at the data. We'll do the comparison. Your data will help inform what we find out scientifically happens to women who do what they choose to do. So I know I'm taking way too much time, but
you said something important. Let me ask and jump on this really quick because I want you to repeat it. You said that even though a woman is in the study and she gets stratified, she gets a choice, right?
Yeah.
She gets a choice. And I think that really debunks a myth that people have about clinical trials, that you're either going to get the one thing or the other thing, but you don't have any say in how that care goes. But you're telling us that if a woman doesn't feel comfortable with the option or the category she's put into, she can have a choice. I think that's really remarkable.
Yeah.
I think I was one of those who they had recommended I do every other year, and I chose to continue doing every year. I think the other great thing about Wisdom is that, you upload your report and then you get your reminder. It helps keep you on track on when you're supposed to get your mammogram. So I think I agree with Dr. Horton. It's an easy study. All I have to do is get my mammogram, which I got to do anyway, and just answer some questions every year and upload my report. It doesn't get any easier than that, but I think the results are going to be so impactful to how we look at screening guidelines.
Right. And now you guys have just lowered your age down to 30 for Black women, which is great.
Right, for all women. So it used to be 40 to 75 were the ages for the Wisdom study. And so this year we lowered it down to start at 30 so we can start answering that question. What happens between women between 30 and 40 in terms of how often are they diagnosed? Which type of women would you expect to maybe be diagnosed, and identify those to start screening?
I think it's also important to recognize that the American College of Radiology a few years ago recommended that Black women and Jewish women start getting risk assessments at age 30. Yes. And what that means is that you go in, you meet with typically, your breast team. They'll ask questions, try and do that risk assessment, and then determine, well, hey, maybe this person, we might need to start getting either mammogram or ultrasounds at age 30 or starting at 35. But it really allows you to have that personalized conversation with a specialist to determine what is going to be the best course for you as far as screening.
And that's what Amanda just did in your office too. So,
I'm putting that in the chat because people didn't even know that they can see a breast specialist before they have a breast concern. Right. But to get that sort of risk stratification, I think is really, really important. So our sister jumping all over this. How's the enrollment and what are the challenges? But Dr. Dunmore, you want to jump in here? I see it.
Well, I was just going to say too, with, and I don't know that everyone knows this, if you have a family member, a first degree relative who has been diagnosed with breast cancer, then you're allowed to start your mammograms at a younger age. So we always tell you, you should start getting your screening at 10 years younger than the age they were when they were diagnosed. All right. So that's important for people to know as well.
Yeah. Right. I think also a lot of people ask me, especially our young women, Mo, what if you don't know your family history? What if you don't know your history, you're adopted or you're in a blended family and no one's talking? And I said, well, err on the side of risk. You know, go
Right.
get genetic testing, go get the testing, go have the conversation with doctors, and just assume that you could have something unless, and then you find out that you don't, great, but at least you're starting that conversation early when it can make a difference for you.
And
that's
genetic testing does start. Sorry, the geneticist will test you, and insurance will cover that if you have no known family history.
Right.
Sorry,
And
Dr.
that's-
Summer.
it's
Mhm.
important too, because like you said, you know, especially in the Black community, we're so hush hush, right? Everything's a secret. When you're at your family reunions, when you're sitting around the Thanksgiving dinner table or the Christmas dinner table or whatever, talk about your family history, right? Ask questions, you know, share if you have relatives or if you've had cancer. Don't keep it a secret. Let your family members know, because your history could really be very important to their survival.
Yeah. And we
And
have
I'll add to that, I think,
Jackie.
we need to talk about all of our health history, because when you look at not only breast cancer, name it, colon, pancreas, prostate, we get these things earlier, and even just our simple health history, high blood pressure, stroke history, diabetic history.
Yeah.
We really have to talk about mental health. We
Right.
really need to talk about these things in our family. So we need to do a better job of just talking about our health history and making it a part of just normal dinner conversation, so we can share that important information.
I'm gonna put in the comments, we have a tool on loveofmygirls.org, our Love of My Girls site. It's a worksheet that you can take to your grandmothers and sit down with them. And it really covers all of the Black diseases that we call the Black diseases. But it's a great conversation starter, because we don't know where to start. And, the grandmas probably don't want to talk about it. So this tool helps you, like, here's how to position it with your grandma. Here's how to start the conversation. How to, sort of, motivate the grandmas to open up and talk about how important this is. Cause I don't know what it is about this, but, and I tell the story, I met this family, at a share conference this summer, where the daughter, she was 38, she had stage 3A triple negative, and they didn't talk about it until she was sick. But her mom and her mom's two sisters all had triple negative breast cancer in the last 2 years.
Wow.
And they never told each other.
Well, give us a couple of those tips though. Like, how do you? Because I know I was on a panel just on a couple of days ago with Laura Cran, and we were talking about this same thing. And somebody put in the chat, it was yesterday, it was SOS. And she said, yeah, but when you're at the family gathering, nobody wants to talk about how Aunt Susie is sick. Like, how do you begin to have these conversations, and what is a good sort of opener and a good way for us to begin to model these things? I wonder if we could throw out a couple of those suggestions for people who are watching, and tease that link, Ricky, so people will go and download the tool.
I recommend starting with, take some 3x5 note cards and pass it out to everybody, and somebody collect them, and then somebody can compile them, and then start sharing that way. Say, like, look, there's 10 cards with high blood pressure at the age of 40 and stroke. Let's talk about who was that, what happened, how can we be better educated so that we can not have strokes at age 40. So I think, getting people to just put something down anonymously then helps to open the conversation.
Yeah, I think part of it too is sometimes, we don't really know even what to call it. Like mom said,
The sugar.
The sugar, she has a bad heart. Like all these like fake names for things, because we don't want to talk about it. But in my family, I deprived them of food. So I started doing it on Thanksgiving. This is probably like 8 years ago now, right after I got better. And I cooked Thanksgiving. So you want to eat my food? So you know how we circle up, everybody has to say what they're thankful for this year before we say grace. And so we have to go around the room. I'm like, okay, what's your PSA? What's your A1C? Did you have your mammogram? Did you get your whatever test? And first they were like really mad. I'm like, well, you want to eat this turkey I cooked? Well, we got to talk, because it's not happening. And so I
show me the numbers, bring your numbers with you.
Bring the numbers, bring it all. And so they hated me, but I think that overall it's now been, now it's like, okay, all right, I have my, and they come with notes now, because they know I'm going to ask the question and deprive them of food.
Yeah, we
Yeah.
did blood pressures after our Thanksgiving dinner. We cleared off the table, and one of my uncles said, Monique, I got these pills, and I was wondering about, and you got a blood pressure cuff? Can you take my blood pressure? And we all had salty turkey and macaroni and cheese and red wine and sangria. We had all the yams and mashed potatoes and ham. Everybody's blood pressure was high, but at least we did it as a family. We talked about it and ways to bring it down and what medications are you on. So it was a good conversation. We're going to do it again this year.
Yeah, you gotta force it. And I think people, I'm not sure, I haven't been able to really identify what the real reason for hiding it is. I think in some cases it's because maybe it's a single mom and she doesn't want her kids to fear that she can't take care of them. I think in some cases it's embarrassment or it's like shame about being sick, right? There's a shame about having cancer, the C word. I don't know. I mean, I've tried to like pick it apart and figure out, what are you hiding? What's the problem? You know, why don't you want people to know?
I
And
think I've heard people say, well, I don't want them to worry. I don't want them to worry. And I always say, well, that's what you do when you love someone. And, especially for the person that's going through the breast cancer journey, I tell them, listen, your job is to just share the information. You can't control the reaction.
Right.
So if they're going to worry, they're just going to worry. If they're going to boo-hoo and cry, they're going to boo-hoo and cry. But, you've got to give them the opportunity to process it and have whatever emotion that they're going to have.
Right.
it's
And
not for their protection too, if they're your kids or they're, they could be impacted genetically or even history. Like I don't have a genetic mutation. And I remember, Dr. Regina, the last time you did my genetic testing, you called me and you said, okay, Ricky, you have no genetic mutations. And I said, well, was that good? And you're like, doesn't really, not really. No, whatever. But
Well, because then to me, it's like then the test is just not important because your history already tells us
no,
what's
I
going
have
on.
generations of history. So
Right.
yeah.
It's not that you don't have it, and not that you do, but it may be that we just haven't been able to identify it. And again, the importance of just getting into some research, having your DNA tested. And I just want to add one little thing about talking to your family. And I've said this, I know, a million times, but sometimes it's just you being that person. So I became the person, and it was easy for me because I'm an oncologist, but I stand up at the family reunion and just say, hi, we're going to talk about cancer. And it's usually about screening, just going through all the, the general screen. I make sure everyone who has a prostate gets your PSA and all of that. But then also saying, because everybody knows that people are affected by cancer, but everybody's a little different about who wants to know. Say that you are the one that is keeping the information about the family. And I like what you did, Regina. I kind of tell people, feel free to call me, and they do, and know that I keep it confidential, but you could maybe hand out cards, or I loved her story sheet because I've used that, and just hand it out. And then when it gets back to me, it gets back to me. Some people take a picture and email it, but then I can tell you, probably 2 months don't go by where someone from my family is calling me saying, I know you know our history and this is happening to me. Do I need to be worried about it? Is it genetic? That kind of thing. But maybe you just becoming that person.
And another thing too, I know this happens at our dinners a lot. Have you been to the doctor? And, my husband or I may initiate that conversation because we are both physicians, but then just butting up, well, hey, you haven't had your mammogram, let's get scheduled and go together. Or you haven't had your colonoscopy, it's almost time for mine too, so let's just make an appointment. Or you haven't been to your primary care, I'll go with you. So just volunteering, because sometimes if people are afraid, just knowing that someone in their family will go with them to help see them through whatever's going on helps too.
Yeah.
I think that's really important because, I found, at least growing up in my family, my grandparents didn't know. They didn't have a high level of health literacy. Even though my grandmother was a nurse, she worked in a psychiatric unit. She was an LPN. She knew some things, but about other things like cancer, she really kind of didn't know. And so she didn't want to talk about it because she didn't know about it, and she didn't want to show what she didn't know. Mm-hmm. And it was that sort of,
Right.
You don't talk about money because you may be not the most financially literate, and you talk about health because those are things that there's people for that. But we would say things like, oh yeah, cancer down there, and just kind of specify a region. And when you ask people, was it cervical? Was it vaginal? Was it uterine? Was it ovarian? People don't know. and we really have to like drill down on it. So you know, you can make it a game. I do with my family, you know, the t-shirts, the family reunion. Can we start to add to the family tree? And you know, CRC, colorectal cancer, can we put a little PC for prostate cancer? And you know, if you have the secret code, you know what it means. But can we start to, as we go through our lineage, really identify who had what and be specific about it? Because you know, it does impact the risk of when you start screening, right?
Right. And you know, you can also be that person at your church. You know, I'm that person at my church. I do a segment every month on the third Sunday of be the CEO of your own health. And I figure out what's the disease of the month. You know, of course, October's breast cancer. And I talk about the risks for Black people, and I talk about, you know, and I've had, you know, several people come up and to the pastor and say, you know, I have mental health issues. I have a history of prostate cancer in my family. And so, and we're starting these conversations now. And at first, you know, people were complaining, well, why is she talking about cancer in service, you know, during worship? And my pastor has been adamant about, because this is where we talk about it. This is where we talk about everything. And taking care of your body and your health is part of worship. And so now it's kind of a routine thing.
I was gonna say, this is a good segue. So all of us on this call are members of the Links, and all of us are also HEAL, right? Members of HEAL. So the
Right.
Links partnered with the American Cancer Society, and we have a program called Health Equity Ambassador Links, and we focus on breast cancer and colorectal cancer. And their modules through the American Cancer Society. Dr. Horton actually led us through Zoom modules too, where you can become a ambassador, and your role as the ambassador is to go back out into the community and educate. So we learn about breast cancer risk factors,
Right.
screening. We learn the same thing about colorectal cancer, what the risk factors are, screening and prevention. And then we take this information and we go back out into the community, whether it be at church, women's organization, a men's organization, anyone who wants to listen to us. We just take the information back out to the community to try to educate. And this way we are hoping to lower the incidence of some cancers in our community.
I love it. And I think we've done some really great stuff with HEAL. You know, people are really using it. We did a breast cancer module in my chapter. And I think pretty much all link chapters did something around breast cancer. But I think we need to be talking about everything too, you know? So.
Our chapter did too, and HEAL was very, very impactful. And we took it to our churches, you know, and individuals who were in sororities took it back to their sororities. And we really tried to sort of, you know, cross-pollinate that information. So initiatives like HEAL, I think, are really they amplify, right, exponentially that message, and they kind of teach people how to do that education. Because just because you know a few things doesn't mean you feel empowered to go out and, you know, talk about it at your church and teach people. But it feels safe when you go, you know, with your chapter or with your Link Sisters and, you know, with your church health committee and be able to take that information to them. So I'd like to think that as a community, we're doing better with health literacy. But what about the remote areas? And what about those areas where, you know, the health literacy is still low? Like what more could we be doing? What innovative things are happening?
And somebody just asked how do I get connected to the Links Ambassador program? I'm not sure, Carmen Marshall, I'm not sure, Carmen, if you're a link or not, but we'll send you some information.
Absolutely. Telehealth, I think, has really, you know, revolutionized. We were talking with like my guardian doc. Their whole goal is to go to communities where access and literacy might be an issue, or where you get a few minutes with your doc or your nurse practitioner, but you don't get all those questions answered. And I think it's still, you know, especially for things like mental health, and for, you know, those sorts of consults, dietitians, nutritionists, navigators, things like that. It's going to be really interesting to see. And I hope the funding and insurance coverage continues to allow things like navigation, because we learned during COVID that, you know, having teleservices really helped our communities a lot.
Yeah. No, that's going to be the big thing, is policy work to make this stuff covered. You know, telehealth, it was a challenge in during COVID. It was a little bit easier, but then they started, you know, pulling that away. And also, well, this is a little different. I was thinking about what you said about rural areas, and not just education, but therapy too, just using decentralization, right? Going out to the patient for certain things, or making it easier for them by getting labs done, not, you know, far away, even if it's the doctor's office, but being a little bit more flexible where the care is actually gotten.
This may seem a little trivial, but you know, I wear my earrings every day. And you can't imagine how many people stop me on the street, in the grocery store, like all over. And even like where I wear pink shoes every day in October. I have on my Barbie.
Oh,
Those are the things.
But people stop me. So even just provoking conversations with strangers, and you know, I talk to strangers everywhere anyway, but I mean, but I think if there's something you can do when you wear a t-shirt, you know, talk about it with people. I talk to women all the time and just, you know, I say, check the breasts that you love. I know you have a pair, to men, women, whoever, everywhere I am. And so I try to make an opportunity to just talk about it. And, you know, maybe this is because it's my God job and I'm crazy, but I think that, you know, we do talk to people wherever we are, you know,
Right.
are out in the world doing our jobs, doing whatever I mean, you guys do this for a living, but even if, you know, whatever you do, make health a conversation with other women in your circle, whatever circles you're in. We're all in these, you know, in the clubs and the sororities and whatever, but make it a conversation when you can, you know, but talk about it.
Something that was a little eye-opening to me with health literacy is I have a friend named Lisa Fitzpatrick, and she is an epidemiologist. She's an infectious disease doctor, but she started this nonprofit in DC called Grapevine Health. And it's literally just about getting the word out, especially in Southeast and Anacostia, about health issues. And she you know, asked for help from all of her friends who are docs. I'm the cancer one, but she does everything. And it started with her, Dr. Lisa on the street, and she will take us out and literally, she puts me on the street at a table with a skeleton so people know it's a medical thing. And just, sometimes she'll make you go up and ask, just stop. Hey, do you have a question about cancer? And it has been the most eye-opening thing. We would go to like street fairs in Anacostia, and I had to go from table to table and talk to the vendors. And I remember one young woman said, yeah, you know, first she thought I was crazy because I said, do you have any questions about cancer? You know, everyone may have cancer questions. She's like, no. And she's like, well, I said, no one, you know, no problem. She said, well, my mom had cancer. I said, oh, okay. I said, oh, she did. I said, what kind? She's like, I don't know. And she's like, might have been up here, breasts. And I'm like, oh, your mom may have had breast cancer, you know, and it became this big conversation about how important it is. But anyway, it just, in your question about how do you get the word out, we just have to be innovative. We have to use a lot of different ways, even if it seems like you're only touching a few, you know,
Right.
Every person you touch is important.
Every person you touch by any means necessary. We
right.
did these focus groups, you know, a couple years ago when we were doing our groups, that kind of led to our manuscript about why do Black women not participate. And we had this woman in a focus group. She was an attorney, Black, very beautiful, Black, well-to-do woman. She had on her St. John suit in the focus group. It was like a Zoom focus group. And she had, her mom had just passed, and she had been her mom's caregiver for 8 years with cancer. And her mom was on a clinical trial. I think it was colon cancer, not breast, but she was on a clinical trial. And so, of course, I dove right into that, right? When I got her on the Zoom, and I said, okay, well, what was her was she taking standard of care? Was she taking the test drug? And she made it clear that she was a very well-to-do, very successful lawyer, you know, Delta, Sigma Theta, Link, everything, all the things, you know, that she's very well educated. And but she had no clue what standard of care was. She really didn't know anything of the basics of a clinical trial. She couldn't really answer any questions about the care that her mother was getting. And it just shows you, it doesn't matter who we are. It's this stuff that we just don't know. We've never been exposed to it.
Right.
And it's okay. I think that however we expose people to it, at what level of whoever you are, it all matters, right? Because I didn't know anything about triple negative breast cancer until my doctor said you have it.
Yeah.
Right.
And my first
I
reaction,
think
that doesn't sound so bad. Right.
I think that's something that's important about the stats that I think people get wrong. I think people think when they look at the stats for Black women, it's women who are uninsured, uneducated, you know, in certain parts of the community. But these stats are for all Black women. no matter no matter your education status, no matter your insurance status. I mean, some of the women that I've seen in my practice with some of the more advanced cancers have insurance and have good insurance.
Right.
And many times, it's these rumors, these things that are passed along in our community that still stay with a lot of women, even when they are more educated, that, they just carry these rumors, those old wives' tales
Right.
kind of stay with them
Right.
throughout their life.
And
Yeah,
so-
it's important to
Oh.
know cancer doesn't discriminate. So
No, cancer does
it
not
really doesn't.
discriminate.
And you
Mhm.
don't know what you don't know.
Right.
I was giving a talk to advocates. These are women who they knew their stuff, and they had breast cancer, and they were, very educated. And after my talk, a woman came up, Black woman, and said, "You know what? I feel a little embarrassed to say this, but I was diagnosed with breast cancer, and one thing happened. She said, I when I was first diagnosed, I really didn't know much about it, and I went to my doctor. I like my doctor, but when I went back to work, I had some colleagues, and I shared, and my colleagues were diagnosed with breast cancer too." And she said they started talking about all this stuff I hadn't heard from my doctor, genetic testing. They had all these things done, and she said, and I don't know what to do. I don't want to, challenge my doctor. I said, challenge your doctor.
Right.
So there are it's so difficult to not know what you don't know. So
Right.
being an advocate, listening to things like this, not being afraid to, make sure that your doctor is doing all the things that he should or she should. In this case, it was a he. And sometimes you don't know, like this woman, but I don't know, it's just very frustrating to me that as someone who was so well educated and everything else felt so uncomfortable, even knowing that she wasn't informed the way she should, going back and just pressing that doctor and saying,
Well,
"Why?"
and imagine how disempowered you feel if you don't have that same level of education. Like I remember my grandfather used to dress up to go to the hospital, right? He would take my grandmother to appointments because they wanted that doctor to take them seriously, and they felt already somewhat disadvantaged from that sort of power position. But I tell people, especially young women, and I'm going to ask all of you to really tell, what do you want people to know coming out of October and throughout the rest of this year? If there were some tips for the rest of the year, what do you want people to know? But I tell young women especially that you can always say, and not just young women, but you can always say, how can we be sure? If you don't know if you're getting, the standard of care, if you think it's, doesn't sound right, or it sounds too aggressive or not aggressive enough, what's the standard? Or like, is this what everybody else is getting? You can sort of ask that question, are there some guidelines or some rules? Right. And then what should I look for at home? If that doctor sends you away and you feel comfortable with observation, then what am I checking for at home? How do I know when to come back? And those are just really 3 great questions that you can ask. And how can we be sure? That way that doctor's not just blowing you off and saying, oh, you don't fit this, you don't fit the typecast, you don't fit the mold for this, so it's probably nothing. How can we be sure, doctor? Right. And it's a great conversation to have. But you're right, Sarah, in that, people don't know what they don't know. And so the other question, number 4, is always, what would you do if it was your loved one, your mother, your sister, your auntie, your spouse? What would you do for them? And that reminds doctors of the humanity, So I would love to get some of that feedback from you all on just tips and things that you want people to know, whether we've heard it this month or not at all. But what do we want people to know coming out of this program and into November?
Can I build on your question, Mo, too, that, we spend most of our time educating women, educating patients. Like, I can't go there to educate white racist doctors. I don't have that in me. But also, because we are dealing with them as patients, how can you help patients know when to ask doctors or know when doctors are not doing right by them? Because not everybody is like you, lovelies. I wish they all were. We'd have health, we'd have health, equity then. But how can we help our patients know when they need to be treated differently?
So I think as a patient, you have to have a level of comfort with your doctor, right? So open communication. So if you feel that your doctor is not being respectful of you as an individual, or if they're speaking down to you or ignoring you or trying to belittle what you may be trying to tell them, that's not good, right? You don't have to stick with a doctor that you don't feel you can talk to. All right. So you see someone, if you don't feel good about it when you leave that room, then you need to look for someone else. You may even want to give them a second chance, right? That's fine. But if you're not comfortable with the way they are speaking to you or the respect you think you should be getting or them answering your questions appropriately, move on. There's no contract that says you have to stay with a doctor. All right. So mutual respect. You have to be respectful of the doctor. The doctor has to be respectful of you. You have to self-advocate. Again, you know your body. You know if you think there's something going on that's not right. So make sure you follow through, right? You have to advocate for yourself. So those would be two important messages that I think patients need to know.
Right. Right. They're only human, and I think that's a good, in your gut if you feel good about somebody or not. And just because they're a doctor doesn't mean they're like, think about if they were a lawyer or if they were the person at the cleaners you go to or your hairdresser. It's that same like connection. If you don't feel it.
And I was going to say, even with things like my hairdresser, well, I won't say my hairdresser because I love her, but, someone who's not your doctor, it's hard for me to kind of question whether I should leave my cleaners. Sometimes you're like, so I can understand how people have a hard time feeling like it's okay to challenge.
Right.
And to build on that, Jackie, one thing that I always say to patients is it's okay to get a second opinion. I mean, especially if it's a complicated case, I'll find a second opinion just so we can get the best minds in on this. One thing I always check too is have people check your insurance company, make sure they'll pay for your second opinion, and then, find an expert. Now, a lot of times they'll do it. You don't even have to go. You just got to get your records to them and you can get these second opinion. It just helps to inform you. Information is power. Doesn't mean you have to leave your doc. And the other last thing I'll say is, in terms of questions, because I know I forget to ask questions too, is I know certain sites, Ricky, you probably have questions to ask your doc. American Cancer Society has them, but even outside of cancer, what you can do is you can Google, I have high blood pressure, Google blood pressure. What question should I ask my doctor? If you have ChatGPT, put in there, what are the questions to ask my doctor? You'll get something and a couple of them will be good. So
Yeah, Mo and I made one for Novartis called More Than Just Words. I'll put that in the chat.
Okay.
Yeah.
Be armed.
Yeah.
What about you, Dr. Regina?
Oh, Regina.
So I just want to leave people with reminding people to get their mammograms. If you have questions about when you should and how often, have a conversation with your doctor. Just to remind people to talk about health history in the family. And I think to realize, breast cancer has changed over the years, and realize just because you knew somebody who was treated 10, 15 years ago, realize your treatment may be different. And so it's really important that, and you may not agree with all the treatments, but it's really important that you at least hear all the information prior to you making your own personalized decision. But I think to realize, so many changes have occurred. When we talk about breast cancer treatment, we're trying to be less aggressive when we can. And I think that the good thing is we're seeing more survivors. We're getting better. We still have a long ways to go, but we're getting a lot better. And please just, as everyone said, you got to just advocate for yourself. If you think something's going on, I think it's that same little inner voice that says, girl, that man ain't no good for you. And you stay with him anyway. But you can listen to that voice and say, nope, I'm not going to stay with this doctor. I'm going to go check with another doctor. So we got to tune into that little voice because it's very important. And it tries to keep us out of trouble, especially with that bad man. But so just advocate for yourselves, ladies.
Yeah. If people enjoy their cancers in your life, they gotta go. That's my rule. It's non-negotiable. Right.
Oh my goodness. Wow. Somebody said what I'd like to take into November is every woman I meet, I'm going to ask if they know their risk factors for cancer. This has been a great eye opener and a door opener, as many have not been connecting the risk factors with breast cancer. So, doing that risk assessment and just asking and checking in with each other, check in with your sisters. It's okay. It's not getting in their business. Right? It is all, we're our sister's keeper, right? We're linked in friendship and service, and that's the cornerstone of what we're about. And that message transcends even the organizations that we are a part of, right? So we have to be our sister's keepers.
Yeah.
Wow,
I
what a joy.
know. Thank you guys so
Mhm.
much.
You.
All right, so this is our first annual, we can do links in pink anytime. Doesn't have to be in October. So let's talk about that and maybe make it part of Heal, you guys. So we'll talk about that and see when we do it once a quarter or something. 'Cause,
Mhm.
we all are supposed to be doing this work as part of our service, so in friendship. So let's do it. So October's gonna be over on we're having a Halloween dance party at 8 o'clock on Tuesday night on the Touch Facebook page. We put the Zoom in our on our Facebook page, and then we start caregiving month.
Mm.
Wednesday, we're gonna have this awesome woman that I met a few months ago named Diane Smith, and she runs a hospice operation in Michigan, and she is a joy. So we're gonna talk about hospice, which is a tough conversation, to have. And I really asked her, how do you decide to say, okay, I'm not gonna fight anymore. I want to go to hospice. I don't want to fight like a girl anymore. You know what I mean? So if any guys want to come on that show with us, it's gonna be on Wednesday. But I think we start to get into, because our caregivers are our lifeline in so many cases, and a lot of us are going through this disease alone, but a lot of us have really great care teams like I did.
Yeah, and November is also Family Health History Month, right? So we can continue the conversation of asking about that family history, take it right in through Thanksgiving when people are gathering. That way you don't have to call them on the phone and be like, did Aunt Sally have cervical cancer? Right? We can ask those questions in a way that doesn't feel so, threatening and invasive, but we can talk about the strength of ourselves and our family. I always say, put it in the context of family strength and overcoming as well, right? Like, this is an awesome and amazing bloodline that we have because of all we've been through together. And what are some of the things that we've been through together, so we can know and be empowered? And I hope that that's something that we take with us, out of October and through November, Family Health History Month, and throughout the rest of the year, is that we're going to stop keeping these secrets in our families, because, those secrets are keeping us sick.
They're killing
Um,
us. Secrets are killing us.
Yeah.
Yep.
Yeah. So there it is. So get your screening, know your risk, and know who to call, because Touch the Black Breast Cancer Alliance is here for you. We got amazing physicians from Howard, from Luminous, from, did I say that right?
Yeah. Luminous Health.
Yeah,
Yeah.
Luminous Health with mobile mammogram vans and community initiatives. We got Dr. Horton here with the wisdom study that you can do out your house, right?
Yes.
Ask about it, ask about us, and get involved. Wow, we hope it's been relatable and reliable and real, right, Ricky? Is what we do every time we're on this platform on Black Doctor. We sure are grateful for it.
Thank you, Black Doctor. Thank you, Amgen. Thank you, Novartis. Thank you to our sponsors, and Breasty Love.
And thank you to the Links
you
Inc.
for
Links
letting
Inc.
me there.
Love you guys. Take care. Love you guys. Bye.
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 Here.